Thank you. At the outset, I would like to thank Sudipto, Dr. Garg and the organizing team for giving me this opportunity to represent the Pediatric Pancreatitis Consensus Group, which met in August after a prelude of meetings to decide the relevant questions. A review of literature took place, the relevant evidences were put into arrived at, and then the statements etc. were finally drafted and finalized during the consensus. So without much, and I thank the Indian Pancreas Club for letting us do this under their umbrella. And it included not only the pediatric gastroenterologists with good experience, but also 5 adult gastroenterologists, radiologists, and a surgeon. So it was the consensus arrived at agreed that the definition should be the standard definition as is accepted by INSPIRE, that is the presence of 2 out of 3 criteria being abdominal pain, which is, mind you, compatible with acute pancreatitis, typical pain happening only in about 1/3 of the children, elevation of serum amylase lipase more than 3 times, and an imaging consistent with pancreatitis. Also agreed to adopt the classification of severity of acute pancreatitis, which is hinged upon the presence of local complications and organ failure. And we all know without any local complications or organ failure, we have mild acute pancreatitis with persisting organ failure, be labeled it severe, and with local complications or with the transient organ dysfunction or an exacerbation of underlying systemic comorbidity, it is labeled as a moderate pancreatitis. Now, coming to the definition of the organ dysfunction, it was decided to adopt the standard, the International Pediatric Sepsis Guidelines of 2006, according to which cardiovascular dysfunction would be defined as a child with a decrease in BP below 2 standard deviations, or a failure to respond to or a need of vasoactive drug to maintain blood pressure in a child who has been resuscitated with a appropriate bolus of fluid, along with 2 of the following, that is acidosis, elevation of lactate usually beyond 5, oliguria, prolonged capillary refill, and either a increased or a decreased temperature or a core is to peripheral temperature gap of more than 3 degrees centigrade, which is a good clinical marker of poor peripheral perfusion. Lung dysfunction or respiratory dysfunction was the adopted definition is again more than or equal to 1 of the following in the absence of pre-existing lung or cyanotic liver disease, that is a PF ratio of less than 300, PCOT which is elevated, and a proven need of more than 50% FiO2 to maintain a saturation of equal to 92% at least, or a need of non-elective mechanical ventilation, and renal dysfunction being defined as a creatinine more than 2 times upper limit of normal for age, or a 2-fold increase from a known recent baseline. Recently we have had the Phoenix sepsis score, which has been updated in 2024, which has added criteria for coagulation and neurological status, but the applicability of the score to acute pancreatitis in children has not yet been validated, so this was deferred for the moment. Coming to the baseline investigations, obviously you have to target investigations which will look at the not only diagnose but also look at the severity and the etiology. So the etiologic factors which need to be addressed are different from those in adults. Specifically, you have to go into the history and do relevant investigations for trauma, infections, especially even viral infections, enteric fever, parasitic, we all know, biliary and pancreatic abnormalities, as has been alluded to. Choledochal cyst is a common cause. Gallstones also occur. Drug-induced systemic illnesses like HSP, HUS, and young children especially may be prone to metabolic disorders leading to acute pancreatitis. So the relevant investigations to the first line investigations, those investigations determine the severity, and in special situations you might even need to do advanced investigations such as TMS, GCMS, young infant 1 to 2 years old with unexplained pancreatitis, low pH, high lactate. So those special investigations need to be tailored according to the situation. It was uniformly agreed with the strong recommendation that ultrasound should be the initial modality to diagnose children who are suspected to have acute pancreatitis, and CT should not be used in the case of routine initial evaluation of acute pancreatitis, being it is to be reserved and should not be used also for routine follow-up without a particular indication. Cross-sectional imaging should be reserved, should be used for diagnosis only if the ultrasound, your clinical picture and the enzymes are not contributory, and CT however may be preferred in cases of trauma to the abdomen and suspected multivisceral injury. So if you're in doubt, do a CT upfront, otherwise don't. Another issue addressed was the need for follow-up CTs. You will often find that patients or children especially land up with a bunch of CTs to your practice. So follow-up cross-sectional imaging should be reserved only in the case of clinical deterioration, or if there are local complications which need intervention, and when you are planning to intervene as a roadmap you do it, you just don't do CT or MRI to follow up local complications. And another important issue which was addressed was the need for MRI, and there is sufficient literature in pediatrics to suggest that MRI should be the preferred modality in cross-sectional imaging in children to avoid unnecessary radiation exposure. The emphasis on enteral nutrition in children is as important and possibly more important than in adults, and it should be encouraged preferably within the first a couple of days of the onset of acute pancreatitis, and even in children with an expected severe acute pancreatitis, they should be encouraged to start enteral nutrition within the first 2 to 3 days as tolerated, and provided they are hemodynamically stable. For enteral feeding, a normal polymeric diet should be used. There is not much evidence for the use of specialized formulae. And in children who refuse to eat, an enteral tube feeding is deemed fit. A nasogastric tube feeding should be initiated, going on to a nasojejunal feeding if the nasogastric tube feeding is not tolerated. Now, I'm aware that the adults have come up with the guideline that Ringer's lactate is to be preferred over normal saline. However, the evidence in children is not so robust. There is only one multi-center trial, but about 70 odd kids. But the only thing that it did show was that it reduces the time to discharge. So not very definite evidence there. So it may be preferred, but the recommendation was weak, and this is subject to change with future investigation. The other thing is about judicious fluid therapy, and obviously the whole problem that we face in pediatrics as in adults possibly is that the kids don't come to us within the first few hours of onset. So you have to be judicious. However, if the child does come to you early enough, then 1.5 to 2 times the maintenance fluid should be instituted, and you have to be very careful though not to push the child into pleural effusion and fluid overload and pseudo lung injury. And subsequently, after the initial 24 to 48 hours, a goal-directed fluid therapy was universally recommended, targeting the parameters like mean arterial pressure, the urine output burn, hematocrit, etc. A step-up approach for pain. It was strongly advocated that opioids should be avoided upfront, and we should step up from paracetamol to NSAIDs, and opioids to be used only in if there's a lack of response to the above, and to switch from weaker to stronger opioids. And antibiotics, obviously, again a strong recommendation and enough evidence in the pediatric literature that it should not, prophylactic antibiotics are not to be used in the first week, especially in the absence of concrete evidence of infection. CRP and WBC count should not be used in the first week of illness, and you may depend upon procalcitonin or the clinical picture of the child, SIRS and other things. There is no role of antioxidants, and there is insufficient evidence to advocate PERT. First thing is that severe acute pancreatitis is rather infrequent in kids, so cannot be recommended at the moment as part of your armamentarium for management of acute pancreatitis in children. The majority of collections which happen in the setting of pediatric acute pancreatitis can be managed conservatively, and that has been shown by multiple groups. They are not as misbehaved as in adults. Intervention, if needed in the early phase, that is less than 4 weeks, is usually for suspected, is advocated for suspected or confirmed infected collections, and after 4 to 6 weeks, it may be required for symptomatic collections which are either infective or causing persistent compressive symptoms or persisting pain. Radiologic intervention was adopted as the preferred mode in the early phase of acute pancreatitis in children, and endoscopic drainage being preferred when indicated and when feasible in the case of walled-off collections in the context of pediatric acute pancreatitis. Surgical necrosectomy, minimally invasive or open, was recommended to be considered in those children who were either not responding or were not amenable to radiologic or endoscopic drainage. And ERCP, it was recommended that the role should be exclusively limited to biliary pancreatitis with due to stones with cholangitis. In a select group of patients with traumatic pancreatitis, though the recommendation was weak, there could be a role of ERCP and pancreatic duct stenting to prevent to overcome the leak. As far as the follow-up is concerned, systematic screening was recommended for abnormal glucose metabolism in cases of severe acute pancreatitis in at 3 months post the episode and at 1 year. Cholecystectomy indicated in all patients with the first attack of gallstone related pancreatitis, and in the cases of mild acute pancreatitis advocated to be done within the first 4 weeks, if not during the same admission, as soon as the patient the symptoms pain resolves. In severe acute gallstone related pancreatitis, like in adults, to the cholecystectomy to be deferred at least for 6 to 8 weeks or after the resolution of the local and systemic complications. So concluding, pediatric acute pancreatitis is a rapidly increasing problem in children, so the need was felt to put forth a guideline. The fraction of children having severe acute pancreatitis is much lower than adults. Ultrasound suffices as an initial imaging modality in majority of the children. MRI needs to be preferred and adopted increasingly for cross-sectional imaging in children with pediatric acute pancreatitis. Fluid management needs to be goal-directed, not indiscriminate, especially in the later part of the presentation, and a step-up approach of pain with opioids best avoided. Early enteral nutrition and a judicious use of antibiotics was also recommended. I thank all the participants, several of whom are here today in the audience, for putting in all the hard work and reviewing the literature and making this possible. And thanks again to the organizers.